Now we are going to have one more plenary speaker today, and then it'll be followed by two fabulous case studies. But first, let me bring up Raymond DuBois. He is the executive director of the Biodesign Institute at Arizona State University, and he's also been working with Mayo Clinic in Arizona at their cancer prevention program. And, you know, he and I were just talking backstage, and we sort of started the morning very broad topics, and now he's going to help us bring it down with some more specificity, focusing on colorectal cancer, the effects of proper screening on clinical outcomes, and also, I believe, a path to stratifying some of those higher risk and lower risk groups so that you can begin to bring this personalized cancer prevention to colorectal cancer. So please welcome Raymond DuBois.
Thank you. Thanks a lot. Well, first of all, I'd like to thank the organizers for inviting me here, and also John Rico for all that he's done in collaborations with ASU and with the Arizona site. What I'm going to talk today is about colorectal cancer and some of the genomic and genetic approaches that are being taken to personalize the treatment. There hasn't been as much progress as you would have thought based on how much we know about the molecular defects in that particular disease. And then I'm going to focus on some areas that relate to prevention and possible chemo prevention. And then at the end of the talk, I'm going to show you some of the data that we've actually generated in my laboratory to obtain a better understanding for how some of these prevention approaches may work on a molecular level. Sorry about that. So if we look at the causes of death from diseases around 1900, and this is the time that the Mayo brothers were practicing medicine here in Rochester. Actually, I think Dr. Plummer joined the practice in 1901 or 1904, and these are the kind of diseases that they were seeing here at the clinic. Just looking at these, you can tell there are a lot of infectious diseases, tuberculosis, pneumonia. People on average died at a younger age because of these types of problems. And today, obviously, we have antibiotics, we have vaccines and other things that can help treat these diseases more effectively. In 2010, it's quite a different picture now looking at the changes in cause of death. There are mainly two main causes, cancer and cardiovascular heart disease, account for 63% of the mortalities that we see. So this is quite a different picture, and I think one that we have to adapt to in terms of our personalizing or making medicine more precise. Each year we spend about $226 billion on cancer care, and there's about 1,500 deaths each day from cancer as a disease. Now, if we break down the causes of cancer, I think it's very revealing, and some of this was alluded to in earlier talks at the conference, but the two, obviously across all cancers, the two biggest causes are tobacco and adult onset obesity and diet. So these are two factors that at some point we're going to have to wrestle with in terms of being more effective in modulating if we're ever going to be more effective at prevention. Worldwide, there's about 1 million people that develop colorectal cancer each year, and about 50% of these will die of metastatic disease within 5 years of their diagnosis. Even though we have mechanisms for early detection that are quite effective and other screening approaches that can really reduce mortality from colorectal cancer. Just to give you some facts, so as you saw in the last slide, it's a major cause of cancer morbidity and mortality. Nearly 150,000 people in the U.S. get the disease each year, or get diagnosed with the disease each year, and there's about 50,000 deaths due to colorectal cancer. The lifetime risk is about 6%, and the average age of diagnosis is around 66 years. So it's a disease that's more prevalent as we get older. One of the problems is the etiologic factors responsible for the disease are somewhat complex and heterogeneous and likely involved important changes in the microbiome that we don't even fully understand at this point. There are known risk factors that have been developed Clearly, individuals with a sedentary lifestyle have an increased risk. People who take a diet that's high in unsaturated fats or high in red meat have a higher risk factor. And then we know there are inherited and or somatic mutations in key tumor suppressor genes and certain oncogenes that I'll talk about that clearly dramatically increase risk for getting the disease. There's also certain epigenetic changes that stimulate cancer progression, and I'll talk about some of those later. And then lastly, we know that use of certain drugs like NSAIDs and others can decrease the risk for colorectal cancer, and I'm going to explore some of those in detail close to the end of the talk. This is just looking at the incidence of disease in the population versus age, and I think it's easy to see that younger individuals have a very low incidence, and as you get older, this incidence goes up pretty dramatically. This data was taken from the SEER database, and I put this red arrow right here at age 50 because that's when it's recommended that individuals start getting screened for colorectal cancer. One of the common ways in this country is from using a colonoscopy, but there are many different ways to screen for the disease, and all of the screening approaches that are taken will reduce the mortality from colorectal cancer. Now, another big problem that we're facing is the changing demographics, not only in the United States, but worldwide. And our life expectancy is increasing, and the proportion of the population that we have above the age of 60 is also increasing very dramatically. And in 2030, it's projected that we'll have over 70 million people over the age of 65. So this is going to incredibly increase our burden of this disease, and that's why I think it's important to really think about more effective ways of prevention now, because this is going to essentially be a tsunami of disease over the next 10 to 20 years. Now, we've learned a lot about this disease from genetic studies that have been done looking at individuals who have inherited forms of colorectal cancer. And the two I've outlined here in yellow are familial adenomatous polyposis, FAP, or hereditary non-polyposis colorectal cancer, HNPCC, or Lynch syndrome. And over on the far right-hand column, you see the genes that are involved in these different genetic forms of the disease. And John Rico showed you earlier an actual gene chip that Mayo has developed to look at all of potentially defects in all of these genes, looking for individuals that are high risk, that have a family history of colorectal cancer. Now, the reason I'm showing you this here is I'm going to show you some data later where some of these genes we've shown are affected. Well, we can delete these in mice or express certain oncogenes in mice to use as models, and I'm going to show you some data from those models later in the talk. Now, this is the multi-step progression model for colorectal cancer shown here. It was really developed by Eric Ferron and Bert Vogelstein at Johns Hopkins. Each year, each 5 to 10 years, it gets refined somewhat, but I think it's a very useful context to think about the molecular changes that occur during the development of colorectal cancer. And this is mainly the model for sporadic disease. There's also colorectal cancer associated with inflammation that goes through a slightly different change of defects in different genes and genetic pathways. But here on the left-hand side, we have normal epithelium. Some of the earliest changes occur in the APC-Wnt beta-catenin pathway, which is a tumor suppressor gene. Those changes lead to a change in the biology of the large intestine that allows for small adenomas to develop. And then later, in many cases, these adenomas can acquire mutation in KRAS or BRAF. And this KRAS pathway has become very important, as you'll see later. And that allows for the development of a large adenoma. These adenomas continue, about half of them continue to have this RAS mutation. And then changes in these other pathways shown here either can activate growth or inhibit some of the other pathways that lead to the development of cancer. And then ultimately, most of the patients die from metastatic spread of disease once it leaves the colon and goes to the lymph nodes or liver or other parts of the body. Now, there are several biomarkers that have been published that people have looked at for indicating either the presence of colorectal cancer as a prognostic factor. but many of these haven't been very helpful in terms of predicting which treatments are going to be most effective. And as you see in this column here, the one that has been most effective is this KRAS oncogene. And this is just some data looking at the impact of KRAS mutations on patients that are treated with an EGFR antagonist. In this case, either cetuximab or panitumumab. And essentially what you see, if there's a KRAS mutation in the tumor, these individuals don't respond to these EGFR inhibitors, and the patient survival is not as well as those that are wild type for KRAS. And this is one of the genes that's been approved by the FDA for companion testing to decide which patients with colorectal cancer can be treated with these EGFR inhibitors. This is just a more recent paper that was published last month in the New England Journal looking at the FOLFOX and EGFR inhibitor treatment and RAS mutations. And again, it was a much larger study, but again confirmed that patients with the mutated RAS do much better with FOLFOX alone. And if wild-type RAS, shown on this side with the hazard ratios, do much better with the EGFR plus the chemotherapy approach. So this is a situation in which we have a marker that tells us which drug not to use for these patients. So it's not exactly telling us the positive, but the negative end of the treatment regimen. So clearly this has become very important. This is again that genetic pathway I showed earlier. This is the EGFR receptor activating RAS. So RAS is really downstream of this growth factor receptor. And as you can see, by having an anti-EGFR antibody blocking the receptor and a constitutively active RAS doesn't really do any good in terms of blocking that pathway. And so if you do some economic analysis of this, you assume there's about 50,000 people per year with metastatic colorectal cancer. The estimated cost savings for patients you're avoiding giving that treatment to, you assume about $8,000. This really would save around $400 to $600 million a year by avoiding giving this EGFR inhibitor to patients who we now know are not going to respond to it because they have a RAS mutation. So this is an example of sort of more predictive or personalized or precision medicine that does have an economic benefit and avoids exposing individuals to drugs that are not going to be effective for their cancers. Now, I want to shift gears a little bit and focus on a little bit more on prevention. This is some text that came from the, I'm told, from the first Chinese medical text around 2600 BC. And what this individual said was pretty interesting given the time and what modalities physicians had to treat patients. In this case, he felt that superior doctors prevent the disease, mediocre doctors treat the disease before it's evident, and inferior doctors treat the full-blown disease. Obviously, they didn't have many medicines. Their surgery was not as well developed as it is now, and so this can easily see how preventing something was better than trying to deal with it once it was a full-blown disease. Now, this is from a review that was done by Hanahan and Weinberg in Cell, and what it talks about are these emerging hallmarks of cancer. One that's become very important is avoiding immune destruction. Tumors have adapted a way to evade the immune system. This is a very important pathway that allows them to progress and avoid immune attack. And then there's also this idea of this tumor-promoting inflammation, where inflammatory pathways are activated, especially in the tumor microenvironment shown here, that really stimulate cancer progression. And I'm going to talk about those later. Now, this is a Google map of the Phoenix area, and the reason I'm showing you this is that if you take a cross-section of a solid tumor, especially a colorectal cancer or other types of tumors, what you get are individual communities that reside in different regions of that tumor that are quite distinct from one another. So, for example, this North Scottsdale area may have a RAS mutation, but down here in, Estrella Village, you may have a P10 mutation or something like that. So what we're finding is that it's not a homogeneous process. There are driver and passenger mutations that are scattered throughout these solid malignancies, and there are already some mutations that are going to allow resistance to drugs before we even treat the patient with that particular drug. So the genomic approach is going to be, it's obviously very important, it's going to revolutionize things, but these tumors are very complex, and we're going to have to determine if we do take a biopsy and we miss, for example, we miss this North Scottsdale region because it's got a RAS mutation, then we go ahead and treat with a EGFR inhibitor. It's really not going to do the patient any good. We're going to have to develop better ways and cleverer ways to assess what's going on in all the regions of these tumors because they're quite distinct. So again, here's the multi-step progression model, and I just want to add in the bottom here, there are factors within the tumor microenvironment such as immune cells, these immune inflammatory cells that are present, they're endothelial cells, there are other pericytes and cancer-associated fibroblasts, and this provides a cellular milieu that produces factors, inflammatory mediators, and other things that can stimulate cancer progression that are somewhat disconnected from these genetic changes that we can easily measure in the tumor sample. For example, this is work done by a group in France and Paris. Jerome Galland has led this group. They've published now about 10 or 12 papers, but essentially they have confirmed this original observation where they show that the type, density, and location of immune cells within human colorectal cancers predicts clinical outcome. So there's a set of cells here with these markers that have a good outcome, and there's a set of cells down here, usually IL-17 positive and others that have a very poor outcome. They've developed an immunoscore that they're using for pathologically marking these tumors, and this also may help us personalize therapy based on if we're going to utilize some immunomodulation for treatment in the future. Now, this is a slide that I stole from Ernie Hawk. Ernie is at the MD Anderson Cancer Center, and he runs the Division of Cancer Prevention. This is looking at several case control and cohort observational studies and essentially looking at individuals who take drugs like aspirin or non-steroidal anti-inflammatory drugs on a regular basis. What we've done here is taken this green area on the left looking at adenomas as a clinical endpoint. In the middle is blue, looking at invasive carcinomas as a clinical endpoint. And then over here on the right is overall cancer risk. What we find is that there's a 40 to 50% reduction in risk of all of these clinical endpoints in individuals who are taking these anti-inflammatory medications. So this created a lot of questions about, what is the mechanism for this, and can we use these as an approach to prevent colorectal cancer? Now, these drugs have been around for thousands of years. The original version of aspirin was an extract of willow bark, and it was used around the time of Hippocrates to reduce fever and inflammation. It was used for centuries in China for headache and other inflammatory conditions. And essentially, the active ingredient of willow bark is salicylic acid, which is the precursor of aspirin, which is commonly used today. Felix Hoffmann was a chemist in Germany. He was the first, he wasn't the first person to synthesize aspirin, but was the first person to synthesize it and market it as this drug, and that happened in 1898. And now, as we know, it's one of the most commonly used drugs around the world. Billions of pounds of aspirin are sold each year, and it's one that we use for many different purposes. The reason we really became interested originally in the connection between aspirin and colorectal cancer is from studies we had done in my laboratory looking at some of the targets of aspirin, the cyclooxygenase pathway, and we found that in intestinal epithelial cells, this pathway was upregulated dramatically following treatment with either EGF or transforming growth factor alpha, shown here. And then when we looked in tumors, there was a significant increase in this COX-2 pathway in colorectal carcinomas or in these large adenomas. And then work done by this Japanese group was able to show if you knock out this COX-2 gene, you get a dramatic reduction of tumor burden in these APC mutant mice. So this is by removing the gene or treating these mice with NSAIDs like aspirin or selective COX-2 inhibitors, it had a dramatic effect on tumor burden. This is the biochemical pathway by which these drugs work. This is a fatty acid, 20-carbon fatty acid, which is converted by these cyclooxygenase enzymes into peroxides, which are ultimately converted by the prostaglandin synthases into these prostaglandins. We found in colorectal cancer and GI malignancies that this PGE2 is the most dominant product made of this pathway. As I said earlier, NSAIDs and aspirin can inhibit these enzymes, and the selective COX-2 inhibitors can block cyclooxygenase 2 selectively. Aspirin also has an effect on this cyclooxygenase 2 pathway. It covalently binds to the enzyme and converts it to an enzyme that produces this 15R heat, which is an inactive lipid molecule, and prevents the COX-2 from making the prostaglandin E2. Prostaglandin E2 has been long known to be involved in inflammation. It's present at very large amounts at sites of inflammation, and recently it's been shown to enhance hematopoietic stem cell homing and also be involved in the development of certain organs in the zebrafish models. So it's got multiple effects during inflammation and on developmental biology. We actually did an experiment where we took the APC mutant mice that have the mutation in the APC gene. We treated them with PGE2 for 8 weeks, and what we found was a very dramatic effect on stimulating the growth of these large adenomas in the colons of these mice. And here on the right, we quantitated this change, and we were able to show that this really did cause a significant difference in the phenotype of these mice by treating them with a simple bioactive lipid like PGE2. And then later, others were able to show that there was there's a connection between use of aspirin and the risk of colorectal cancer, but it's also correlated with the expression of COX-2. So Andy Chan published this some time ago in the New England Journal, and essentially the conclusions from this study were that, again, regular use of aspirin reduces the risk for colorectal cancer, but it really was only effective in those individuals whose tumors express the COX-2 gene. So this is a very interesting development, and one where you can actually use this as a biomarker to predict which individuals are going to be responsive to these agents. Then just recently, John Byrne published this study looking at the long-term effect of aspirin on cancer risk in carriers of hereditary colorectal cancer. In this case, it was the HNPCC Lynch syndrome. And what Professor Byrne did was he randomized individuals to either treatment with aspirin or placebo. He used a very high dose of aspirin, in this case 600 milligrams per day. And what he found was in the aspirin treated group, or comparing the placebo to the aspirin treatment, there was a significant difference in the incidence of cancer in these two groups of either treated or placebo, and for the first time really published the results showing that aspirin could reduce the incidence of colorectal cancer, especially in this very high-risk group of individuals who have inherited the mutations to develop this disease. So this really raises an important question. How could drugs that are meant to reduce pain and inflammation also affect cancer progression? This is a very fundamental question that we've been asking for the last 5 to 10 years. What we found was when we treat colon carcinoma cells with PGE2, it changes the expression of a number of genes that are involved in these hallmarks of cancer. In blue, we have the upregulated genes. In green, we have the downregulated genes. And these can either inhibit apoptosis, they can inhibit immune function, they can stimulate inflammation. There's a lot of factors that are affected that affect tumor-associated angiogenesis, and also can affect migration and metastasis of these colon carcinoma cells. That raises the question, is there something that we can do with, or do these agents somehow protect the genome in some way? And there was just a paper published in June in this past summer looking at individuals that were treated with NSAIDs and then looking at the clonal evolution of cells in the esophagus in Barrett's esophagus. What the conclusion of this PLUS Genetics paper was, when they took biopsies from these patients that were either on aspirin or not, the individuals on aspirin had a 10 times more slowly accumulated new mutations than the ones that were off aspirin. So this is telling us that somehow we're affecting the mutation rate of individual genes in people who take these anti-inflammatory drugs. And so we think we know the mechanism for this now. We actually published this paper in Nature Medicine last year where we showed that PGE2 can actually enhance the expression of the methyltransferase enzymes both in vitro and in vivo. In this slide, we're doing immunostaining, looking at these enzymes in the tumors. They go up very dramatically. When we treat individual colon carcinoma cells with PGE2, we get a dramatic increase in either DMT1 or DMT3B. We can actually freshly isolate colonic tumor epithelial cells from animals or from humans, and we treat those with PGE2. Again, we see a very significant upregulation of these methyltransferase enzymes. So the question we wanted to ask, does this have any effect on the tumor biology that could lead to progression of the disease? And obviously what we found was it did affect the methylation of some very important genes that we know are involved in progression of colorectal cancer. This MGMT and MLH1 are genes that are very important for DNA repair. So we examined their promoters in the presence and absence of PGE2. And essentially what we found in the control, a very low level of methylation of this crucial part of the promoter of these two genes. And then when we added PGE2, there was a significant increase in the methylation of these bases, showing that it had epigenetic effects on these pathways. The MGMT gene is particularly important. It was shown some time ago that if you inactivate this DNA repair gene, it's actually responsible for the G to A mutations in KRAS that happen during colorectal tumor genesis. So this is a direct effect on increasing this pathway that leads to tumor progression. We also looked at other genes that essentially were recommended by the reviewers of the paper as well, and we found again the same type of concept where methylation increased following PGE2 in these two situations, and we were able to prove that this happens in vivo as well as in vitro. We went on to look at the expression of the proteins and RNAs, and we found again that the PGE2 treatment silences the expression of these genes by methylation of these promoters. We did some preclinical studies in the laboratory to determine if we use inhibitors of these pathways, what type of effect do we get? So in this experiment, we used the APC mutant mice. Again, we treated with either control or PGE2. And as I showed you earlier, we get a significant increase in the number of tumors that develop both in the large and the small intestine. And then if we treat with azacitidine in addition to PGE2, this inhibits the methylation of DNA. We can return this back towards the baseline, indicating that this is one of the important effects of PGE2 on increasing the methylation of these genes. We also did some combination therapy using an inhibitor of both COX-2 and DNA methylation. And essentially what we found here is the control situation. When we combine the methylation inhibitor with Celebrex, in this case, celecoxib, we get a very dramatic decrease in the number of polyps and also the size of polyps. Usually these animals die from their disease within 3 months of birth because they either have an intestinal obstruction or anemia. We've been able to maintain these animals on a combination of azacitidine and celecoxib for over a year, so it really does have a dramatic effect on increasing their survival and reducing their mortality from the tumor burden. So just to summarize this part of the talk, clearly PGE2 silenced certain tumor suppressor and DNA repair genes. Combined treatment of these mice with COX-2 inhibitors and methylation inhibitors was very effective. And levels of this PGE2, COX-2, and the dimethyltransferases were also positively correlated with methylation of these mismatch repair and tumor suppressor genes. So I'm just going to, in the final minute and a half I want to show you some data that we just generated recently, and it just got accepted for publication in Cancer Cell last week. What we did was we looked at some other genes that are affected by this PGE2 pathway, in this case CXCL1 and CXCR2, which which are chemokine ligands and receptors. We actually were able to develop this model with chronic inflammation, stimulating with dextran sulfate, and we were able to knock out the CXCR2 gene. What we found was when we knock out this gene, we get a dramatic decrease in the amount of inflammation that occurs in this DSS model that I've shown you here. And then if we measure the tumor burden in this situation, we get a significant reduction in tumor burden when we knock out the CXCR2 gene, which is upregulated by PGE2. So we think this is a very important downstream pathway. Lastly, when we look at the wild-type mice treated with DSS and then examine the tumor microenvironment for all of the immune cells that are present there, we find a very high number of these myeloid-derived suppressor cells, or MDSC cells. These cells inhibit the ability of these tumors to have an immune response from the body. And then when we knock out this CXCR2 pathway, we completely eradicate the presence of these myeloid-derived suppressor cells in the tumor microenvironment. So in closing, I just want to acknowledge the individuals in my laboratory that were very helpful for this work, and our collaborators from Cincinnati Children's Hospital in Ohio, and then also Walter Wally and Beatrice for their help with providing us with some of these animal models. So I'll stop there.
Thank you so much. Before we get to some of the audience questions I know have been coming in, and don't forget for anybody else out there to use the app, and you could still send a couple in. But one thing that I was curious about, from a patient perspective, what are some of the potential benefits and risks in going down this path?
Yeah, that's a great question, and I think, as you know, many people are currently taking aspirin for issues related to cardiovascular disease. And so, for those individuals, there are some GI toxic effects associated, especially with the higher aspirin dosage, ulceration, bleeding, and other things. Some of those can be remediated somewhat by taking a proton pump inhibitor along with the aspirin. For the selective COX-2 inhibitors, they're still widely used in patients with rheumatoid arthritis, but it's not good for individuals to take those who have known risk factors for cardiovascular disease, like if they've previously had an MI or a thromboembolic stroke, they're at risk for exacerbating those diseases when they take those selective COX-2 inhibitors. So, you have to be very careful with that. And I think the idea here, and this is the whole idea of sort of personalizing the prevention approach, is to look at the relative risk and the relative benefits in individual patients. There are certainly individuals that tolerate these drugs and don't experience the side effects. And if they have a higher risk, especially those patients with Lynch syndrome or some genetic predilection for colorectal cancer, then the benefit would probably outweigh the risk. Right. In individuals who have very low risk for colorectal cancer, no family history, they exercise regularly, they get a good diet, lots of sleep, low stress, they probably don't need to be taking things like this anyway.
Wow, that description sounds so nice, doesn't it? Lots of sleep, low stress. I need to sign up for one of those. And we have some questions coming in, so why don't I go to the first one here on the screen, and it's asking what you foresee are the major breakthroughs in colon cancer field in the coming years, and where does genomics fit into that?
That's a very good question. And I alluded to this in my talk. It's been a little bit disappointing, especially in colorectal cancer per se, because we've known about these molecular defects for over a decade. A lot of this work was done originally by using a candidate gene approach. And then since then, several colorectal cancer genomes have been sequenced. It's verified the known genes that I showed in my progression slide, APC, KRAS, BRAF, and PTEN, and others. We're still using pretty much the same treatment that we had before. The big change has really been the idea that if there is a RAS mutation Those patients don't respond well to the EGFR inhibitors, so we can avoid treating them with that. In fact, there's evidence that if they do get treated with those EGFR inhibitors, they tend to do worse than individuals that are just on the chemotherapy alone. So I guess the biggest thing that has happened so far is using RAS as a decider about whether or not to use the EGFR inhibitors. Now, one of the things that from the whole genome approach in colorectal cancer is each tumor seems quite heterogeneous. So if you look at individual tumors from different patients, they have a common array of mutations, the ones that were shown, but then there are other mutations that occur that are quite different from one another. And I don't know if that can be used in some way. It's still, you know, some adaptive design trials have been, are looking at using different targeted therapies to see if there's a combination of those that would be better in a certain subset of those patients. But we haven't made as much progress, for example, as breast cancer and some other cancers.
Right, right. Interesting one here. This questioner brings up the line between hereditary and non-hereditary colon cancer seems to be getting less well defined. Essentially, is all colon cancer hereditary at some level?
Well, there is a very strong hereditary component, it looks like, and you know, there still are some other hereditary genes out there that haven't been clearly defined yet, but it is very interesting that if you look at the genes that we know cause the hereditary forms, they're also affected somatically in the tumors that develop spontaneously. So the big difference, I guess, is the age at which the cancer develops in patients who have inherited those mutations through their parents. They usually develop colorectal cancer at a very young age, you know, either, you know, early 20s or, you know, certainly by the time they're 40. And then if you look at those that develop sporadically, they usually develop much later after the age of 50, usually during the age of between 60 and 70. Okay,
okay, good. Share with us what some of the current barriers are to implementing personalized cancer prevention. I mean, it sounds like such a marvelous goal, but you must be seeing some of those challenges, experiencing them.
It's a big challenge, I think, because you know, because anything you do, you know, with a drug or any kind of medicine is going to have a risk of doing something negative. So whatever you do, you have to make sure that there's enough benefit from that approach to overcome whatever the risk is for taking those. We already, you know, have several screening programs that are going throughout the country. It's recommended to get screening for colorectal cancer at the age of 50. It's paid for by Medicare, so that, you know, I think that was a great achievement. And then really nice studies have been done showing that individuals that undergo that type of screening have a much lower, 40% lower mortality from colorectal cancer. So that's an answer that we already have. The problem is that it's so costly to screen everybody in the population over the age of 50, and a lot of people don't like to go through the colonoscopy, as you might know. So the idea now is to create a biomarker that could be a blood test, a stool test, or some sort of biomarker that increases your concern about developing colorectal cancer or having these polyps, and then stratify the population so that those individuals would go on to the colonoscopy screening. That'll reduce the cost dramatically, avoid the test from people that don't really need it. And there are research underway looking at potential biomarkers. There's nothing that's been validated yet, but that really could be a paradigm changer in terms of preventing colorectal cancer.
I would think so. Another question from our audience, have you looked at anti-inflammatory fatty acids, such as omega-6s, for instance, since PGE2 is also a fatty acid pathway? And are there any adjuvant properties of these omega-6s?
Yes, I haven't looked at that specifically in my laboratory, but it has been looked at by others. And there is a reduction in tumor burden in animal models who take these omega acids. And, you know, they do inhibit these pro-inflammatory pathways in a number of different ways. So there is a benefit to that. You know, some of the fish oils and those types of fatty acids are effective. Sometimes people have a hard time taking those, and you know, you don't want to go around smelling like a fish all day and all that. But, You know, they are effective, and I think they prove that inhibiting this inflammatory pathway can work.
I'd opt for salmon over smelling personally like a fish.
Exactly, just increase the fish in your diet.
Okay, so whoever sent this question in, I'm going to find you and get you later, because if I can pronounce all of these, I'll be
You
really...
want me to read it out?
Let's give it a try here, Ray. Are there other epigenetic changes associated with CRC, such as histone hyper or hypo acetylation, along with DNA methylation?
Good job. There are, and we're just now studying those. There are inhibitors of acetylation that you can use in these models, and we've shown that they do reduce the tumor burden. So clearly there are other epigenetic changes that are also important. We were just focused on these particular ones that I talked about today because we were able to show that the prostaglandins directly modulate their levels.
Sure. And as our clock ticks down, I think this is a great practical one for everybody. Is 600 milligrams of aspirin too much for the average individual to take on a daily basis?
That's a very high dose of aspirin. And actually, I asked Sir John Byrne this question because normally, you know, individuals with risk for cardiovascular disease take a lower dose of aspirin. The one pill that you get at the pharmacy here is 325 milligrams, and 600 is probably too high. I think at that level, you're going to get side effects that you wouldn't see with the lower dose of aspirin. Now, in the study that I showed you from the Lancet, he didn't have enough patients to do multiple different dosages.
Right.
So he didn't want to use a dose where he would miss this kind of effect. So they went for the highest dose. They did describe in the paper that they didn't observe any untoward side effects in those individuals, but I don't know how carefully they looked for those. So clearly, I think 600 is too high.
Too high, and maybe future studies, they'll be able to try a couple different dosages?
Yeah, there are a lot of people now interested in looking at this. That study was incredibly difficult to do because you have to have patients who have this genetic syndrome and are going to be available for this long-term study. But I think it's going to be important to see if a lower dose is going to have the same efficacy.
Wonderful. Join me in thanking Dr. DuBois.